Hi everyone, this is my presentation on intimate partner violence and sexual assault. What does intimate partner violence look like? Intimate partner violence, IPV, is a pattern of assaultive and coercive behavior that may include physical injury, psychological abuse, sexual assault, progressive isolation, stalking, deprivation, intimidation, and reproductive coercion. These types of behaviors are performed by someone who is, was, or wishes to be involved in an intimate relationship with an adult or adolescent and is aimed at controlling the said person or adolescent. Sexual assault is any non-consensual sexual contact. Intentional touching without consent. Rape in most statutes is defined as non-consensual oral, anal, or vaginal penetration of the victim by body parts or objects using force, threat, or bodily harm, or by taking advantage of any individual who is incapacitated or otherwise unable to give consent. Women are more likely to be sexually abused, and those who have been sexually abused are more likely to suffer from sexual violence, intimate partner violence, or be a victim of rape later in life if they have at one point been sexually abused. Rape accounts for 5 to 10% of the violent crimes in the United States, and it is the most underreported crime in the nation. 1 in 3 women will be sexually assaulted in their life, and 1 in 5 women will be raped. Epidemiology. This can occur in any couple, in any person, heterosexual, same-sex, non-gender conforming couples. It can happen to anyone regardless of age, race, religion, socioeconomic status, sexual orientation, educational background. That should be absolutely stressed. No person, community is immune to intimate partner violence. Individuals who are subjected to this intimate partner violence can have lifelong consequences, including emotional trauma, lasting physical impairment, chronic health problems, and even death. 1 in 3 women will experience rape, physical violence, or stalking by an intimate partner in the United States in their lifetime. And then another sad statistic is 4.1 million instances of physical and sexual assault occur in women annually in the United States. In 2007, it was reported that intimate partner violence resulted in 2,340 deaths. However, we don't know the exact numbers because intimate partner violence is often not disclosed because people are afraid to come forward, and that is often why we don't know the exact number. Risk factors for intimate partner violence and sexual assault. This is not a cohesive list, just some examples of what could cause someone to be at higher risk for intimate partner violence or sexual assault. At the top of the list, low self-esteem, low education, you're young, maybe you had aggressive or delinquent behavior, you are heavy into alcohol and drug use, you have depression and suicide ideation, you've had lack of nonviolent social problem-solving skills. You've had a history of being physically abusive. You have few friends and are being isolated from other people. Again, that's just some of the few. And then towards the bottom, I think it's just important to point out that people who have strict sense of gender roles, in the sense that the male dominates and should be the alpha in any given couple, could be at an increased risk for intimate partner violence, and just overall people who have hostility towards women and the attitudes that women are inferior and that violence is justified. And you're at increased risk for intimate partner violence if you have a history of emotional abuse in your childhood. Just quickly, I thought this was interesting. A look at intimate partner violence in COVID. I don't know if anyone ever had this brought to their attention during the pandemic, but the rates of domestic and sexual violence were going up at an alarming rate when the stay-at-home order started because of people's, isolation and us not being able to help those individuals because they couldn't access support and programs, and we had to social distance. So that was one of the really horrible outcomes from our isolation. Common subjective and objective findings in IPV. You might see bruises, you might see broken bones, you might see patients who are emotionally abused and they feel belittled, patronized, threatened, ignored, or rejected. Sexual abuse may present with injury to the peri area. However, they might have a story, but the injury does not correlate with the story. Or patients might not have any symptoms, or they might endure secondary symptoms like I have a lot of anxiety, I have headaches, GI distress, I can't sleep. But it's most important, and it needs to be stressed, that patients need to be interviewed alone. There should not be anybody else in the room, especially their partner. They need to be just with the provider in order to be able to freely endorse what's going on. Common subjective, objective findings in sexual assault. Patients might report various physical and psychological issues. They might have anxiety, fear, depression, PTSD. They could or could not be forthcoming with talking about their assault. Objective findings could include torn or stained clothes, visible injuries, edema, lacerations, bruising. They might have trauma to their mouth. They might have dried secretions to their face, mouth, and hands. They too could have broken or fractured bones. It's important to look to see if they have any foreign objects still within them. Their genitalia may have edema, bruising, lacerations. And their Bartholin's and skiing glands may be extremely tender when you're doing a pelvic exam. Uncommon subjective and objective findings. I think it's just really important to highlight that inter-partner violence and sexual assault, it can look really different in all scenarios. It's not one size fits all, so providers just really need to use their discretion and their medical expertise to kind of investigate further if it is suspected. Just some differentials, not that they're diagnoses, but just to consider that maybe this physical trauma was from an accident, and we are in the age of, being sexually open. So sometimes people do have consensual intercourse that has some BDSM or specific consensual kinks. So we have to just understand if these were wanted and consensual acts and not, of course, something that they did not want. Potential secondary abnormal findings could include sexual dysfunction, vaginal dryness, tight pelvic floor, low libido. Plan of care. Pharmacologically speaking, if this patient is not impaired by drugs or alcohol, they can be given anti-anxiety medication, antidepressants, pain relief. If they have been sexually assaulted, they can be treated for STIs. If the patient declines, then they should be retreated in 2 weeks. But if they were to be treated, they should be treated for gonorrhea, chlamydia, and trichomonas. If they also should receive post-exposure prophylaxis for HIV, and they should receive a pregnancy test. Emergency contraception is given regardless of menstrual phase, cycle phase, as long as the patient is within 5 days of the assault and there is a negative pregnancy test. Non-pharmacologically speaking, we provide emotional support at every step of the way, and we must explain all steps of our assessment so the patient feels most comfortable. And we need to tell them specifically that we are collecting for forensic evidence, and it's best to collect within 120 hours of the assault. Education-wise, you should review the duties and the procedures of the SANE nurse, unless the SANE nurse will be doing so. The patient should be educated that this is a safe space and that the hospital and/or clinic uses safety measures to protect them. And the patient needs to be advised they need to use condoms 3 months after their assault because they could have been exposed to blood or bodily fluid, and they need to avoid pregnancy. Plan of care continued. Health promotion. We should you do a drug toxicity panel for them if they had been given a drug and or were intoxicated, or they were given a date rape drug. They should be given post-exposure Hep B vaccination if they not previously received it. Psychological needs is us giving them the space and time to grieve and talk if they so wish. And then the referrals are really, really important and must be stressed. Social worker needs to be involved, especially with inter-partner violence, as they need to understand that it is the most dangerous time for the woman to be leaving. A counselor needs to be connected to both patients of intimate partner violence and sexual assault. Police involvement needs to be involved if they would like to press charges. And patients should be seen within 20 to 48 hours after discharge from the hospital or clinic. It needs to be stressed that routine screenings for intimate partner violence need to occur at every wellness visit. And these are my references, and thank you so much.